Sorry. The agenda.
Okay. Oh, never mind.
Meaning to like.
The agenda's on the other side.
Oh, it is.
Yep. Okay, and I think.
I have it now.
Secretary will. Late, but.
Um. Okay. So good afternoon, everyone. I'm gonna call the September 18th MHBE board meeting to order. The first task of this meeting is approval of the minutes. They were all sent out via email, and if you've had a chance to review and are ready to make a motion, if we could get a motion to approve the minutes.
So moved.
There's a second.
Second.
Any discussion or questions about the minutes? Any opposed? Okay, minutes approved.
Any public comments?
Public comment? Okay.
Well, thank you, Secretary Herbert Scott, and I'm happy to give an update this month. We did not meet in August, so there's been a lot going on, but first item of great importance is that thanks to our insurance commissioner and the Maryland Insurance Administration, the rates, individual, small group and dental rates have been approved and released. And very good news for the state of Maryland is that the individual market rate increased. It did increase, that's not good news, but it increased by 4.7%. And what we're seeing, to put this in context, what we're seeing across the nation is anywhere from 3% up to 15%. So it's all over the board this year. And I think what will start to play out is seeing what states have done to keep rates low. Of course, in Maryland, we've got the reinsurance program that has really helped. Also, our claims expenses and trend has come in lower. You'll hear a lot more about this from Brad Bobin, who's here to give us a presentation, the board a presentation on that later in the agenda. But the good news is that for most of our consumers on the exchange, this will be offset by their tax credits that they get. And for those that might be affected, we of course do want to, and we'll always continue to encourage people to come back and shop for new plans, because we also this year have a new carrier on the marketplace. So Aetna CVS Health has joined the marketplace. As you may recall, they were part of the marketplace when we started way back when. So now statewide, there will be 3 insurance carriers fully statewide, and then Kaiser in a majority of the populous areas of the state. So that's a big news to lead off with today. Our staff, now that we have the rates, will be making sure that they're loaded into the system, that they're correct. We'll be testing against what was filed. And then we will be executing the renewal notices that will start hitting mailboxes at the beginning of October. So that's our big focus now. Those notices were required to get them out a month before open enrollment. The exchange has also been working with our sister agencies on lots of things in preparation for the upcoming legislative session, primarily on several reports that we've been required to participate in or asked to participate in. House Bill 413, which is an effort led by the Maryland Insurance Administration with participation from the exchange and from MHCC. And that bill really is looking for us to evaluate the reinsurance program and evaluate market-wide and other functions that we could do as a state to really make sure we're providing health coverage for Marylanders and that the program is doing what it is intended to do. So that report is due back to the legislature in December. Also, second area we're working on is with Maryland Department of Health on SB 806, which is healthcare and dental care coverage for undocumented immigrants. And that, and just as a reminder, was to look at what the cost would be to the state if we expanded Medicaid coverage to the undocumented population. So that report is due in October, and the exchange has been participating in that. And then finally, we're working with HSCRC, Maryland Healthcare Commission, and the exchange and Maryland Department of Health, looking at ways to, again, make sure that the healthcare coverage we're providing in this state is very beneficial to Marylanders. So that's another effort underway. At the federal level, Medicaid unwinding, or as it's being referred to as the return to normal, of course, is still front and center. The exchange has been doing a lot of activity, both in consumer assistance, in information technology, and in our outreach efforts to really support this. So we implemented through our system, we implemented a continuous coverage for consumers under the age of 19. We are continuing coverage for those that have under 100% FPL, federal poverty level. We are implementing an ex parte, which in commercial terms, the automatic renewal at the individual level instead of at the household level. That means when we're doing those renewals, we're looking at each person, not the household as a whole. We've been doing direct email, chase email, texting, and surveys to really try and get a sense of where folks are moving, shifting to, that are going out of Medicaid and coming into QHP. And then probably the best thing that we did, and this wasn't intentionally designed for the public health emergency unwinding, but it really has given us tremendous benefit, was implementing a chat feature within our application. And so as folks are in the application and they're getting stuck or they're having questions, they can connect with our chat feature right there. And that has allowed those consumers to really be assisted immediately and not put extra pressure on the call center. So we've seen just terrific response from that. And that was an unintended positive consequence of that technology enhancement. Another item that again affects Medicaid, but we've been heavily involved in through the system, is implementing the Healthy Babies Equity Act. And this was effective July 1st. And this is for non-citizen pregnant individuals in Maryland to have access to Medicaid coverage. Originally, the original enrollment was projected at 6,000 total, and this was, I think, as of July, was already at 3,800. So just really good effort from that and from our Department of Health and getting the information out. But we're happy that that is part of the system. In terms of just some data and other staffing issues, our August data report is now online. And again, I really encourage everyone to go there. For our legislators, we've put all the enrollments in there based on their legislative district. So very easy to go see where those enrollments are by each district. In our current report for August, really good news to report. We're seeing our enrollments obviously continue to increase as Medicaid numbers are decreasing. Our commercial insurance is increasing, which is terrific. We are again seeing our populations, our target populations, our Hispanic consumers were up 27% compared to a year earlier. Our Black and African American consumers increased by 13% compared to a year earlier. And our young adult enrollments, another focus group, reached over 53,000 at the end of August, and 37,000 of those are receiving a state subsidy, our new program. So again, just really good results coming out of our programs. On the small business side, this has been a focus of ours of late, and hired two just incredible people that are spearheading a renewal of us getting small businesses enrolled. And one of the things that we recently saw was a partnership with Maryland House Health Business Express website. So now for anyone going to the Maryland Business Express website looking to start a business, they can automatically get connected to Maryland Health Connection for small business for more information on how to provide health coverage. And I think I will stop there and happy to take any questions.
Any questions for Michelle? Thank you, Michelle. So next we'll move on to board committee reports and we'll start with the policy committee. Michelle, I think that's you again.
I am going to provide an update. Dr. Allen is not here, but most everything, well, actually everything that the policy committee heard, you are going to hear today because it was all about the regulation updates. So we have a good presentation on that.
Great. And next, finance committee. Ben, I understand you're providing the update.
Sure, I'm filling in today. The Finance and Audit Committee met last week. We had several agenda items we covered. The first was a presentation by Scott Brennan, who provided an overview of some recommended policy changes regarding the director's ability to report directly to the Audit and Finance Committee directly, as opposed to the manner in which it occurs today, which is through the executive director. The compliance director did raise some important points about why that would be in some situations important. And the two members of the Finance and Audit Committee agreed that that should be something that will be carried forward, part of the internal policies of the MHBE. Scott also provided an update on the Office of Legislative Auditors that's begun the 3-year audit of the Maryland Health Benefit Exchange. That's for those not in Maryland government. That's routine auditing that occurs for all state agencies. Naturally, the MHBE is an area that's important because of the key role we play in providing insurance coverage. They began in July. The report is they'll continue with initial findings, if any, provided to staff later in November. The key areas that Mr. Brennan pointed out they seem to be interested in was the reinsurance program, as well as more broadly the MHBE fund. There's expectations that the final report, or the draft report, would be back to the commission staff late in November, with of course the notifications on what findings there would be made to the entire board. He also mentioned that the IDIQ work that had begun this summer in terms of obtaining disclosure information from the IDIQ consultants, vendors, was nearly complete. Of the 30, I believe it's 37 of the 39 vendors had submitted their financial disclosure forms, and they're awaiting 2 more. We also got an update on the submissions of the MHBE to CMS. The privacy impact assessment had been submitted to CMS at the end of June, and staff is awaiting responses on that information. Lastly, Tony provided an update on the preparation of the FY 2025 budget. As many of you know, budget documents are not public until they've been approved and released by the governor. So the information is not shared in public session, but the financial folks at MHBE are doing a good job of being financially responsible and also responsive to inquiries from DBM and others that have an interest in knowing where things stand. That concludes my update. Happy to.
Hi, I just want to thank Ben for presenting the report. The finance committee meeting was so long, we had to do it over 2 different days, August 7th and September 13th. And I was unable to attend the September 13th meeting. So I requested Ben, and Ben, thank you very much for the report.
Sure.
Any other questions for Ben? Great. Then we'll move on to the Standing Advisory Committee. Dana? For your update.
All right. Happy to report that our meeting also went long, and one reason it went long is because of interest by the members. Our co-chair, Dr. Mark Meiselbach, who happens to be a health economist, who also does research focused on private health insurance markets, opened the meeting and of course welcomed members. As usual, the members appreciated the executive update by Michelle Eberly. Noting the high cost of diabetes, now I'm moving into the meeting itself, and related conditions and the high prevalence and ever increasing incidence of diabetes in Maryland, it was recommended to have a SAC meeting addressing this condition. As part of that discussion to include it on the agenda, I expressed my interest in the upcoming presentations and discussion on diabetes prevention and treatment mitigation efforts to the SAC. Overall, I'll get to the presentation presenters in a bit, but overall, there are some common themes and efforts across the organizations that presented, and the focus tended to be on diabetes 2 and pre-diabetes. The providers talked about their in-person and virtual support programs and also case management that included diet, food intake, exercise, medication, insurance coverage of diabetes related treatments and medications. The presenters were Pamela Williams from the Maryland Department of Health Bureau for Cancer and Chronic Disease, and she presented on the Diabetes Action Plan of the state of Maryland. As a bridge from her presentation to those of the exchange carriers, our own Johanna Fabian Marks reviewed the diabetes-related benefits and impact on reinsurance, such as the state laws, the MHBE value plan, state reinsurance program. And United Healthcare had 2 presenters. One was Dr. Ashraf, and the other was Ms. Reva Gershon-Carr. And like I mentioned, there was a lot of similarity in terms of focus across the presentations. Move on. From Kaiser Permanente, we also had Stacy Shapiro, who gave an overview of coverage and programs. From Care First, we had Tracy Gramp and Ashley Freed. All right. Now, these presentations stimulated robust discussions, such as comments, questions, and answers. And given the keen and active interest by the SAC members, the meeting went on a bit longer than planned. In conclusion, I would like to remind my colleagues on the MHBE board that this Standing Advisory Committee has representation across stakeholder groups with varying degrees of experience, expertise, and interest. We have researchers, health economists, brokers, carriers, policy advocates, professors, et cetera, et cetera. And I encourage us to benefit from this rich resource to provide feedback and or to do background and other research for issues we may face. Yes, that pretty much concludes it. I'd be happy to take questions. That's okay with the chair.
Any questions for Dana and the Standing Advisory Committee? Okay, no questions. Thank you, Dana.
You're welcome.
So next we'll go on to board hearing for the final regulations.
Good afternoon, everyone. Nicole Quigley, Assistant Attorney General. And today we're discussing potentially obtaining the board's final vote for implementing hearing procedures for hearings that the board will preside over. The process for implementation of this chapter began a few months ago, and there are a few new board members to the board. So I'll provide a little bit of a background, brief background, so that everyone's on the same page. In June, by recommendation of the Board Policy Committee, the board implemented a final vote to delegate producer appeals to the Office of Administrative Hearings, the OAH. That gave the OAH the authority to preside over those hearings. And in delegating those appeals, the board approved changes to that chapter of MHBE's regulations to reflect that delegation. Part of that change included removing hearing procedures from that chapter because OAH has their own hearing procedures. However, there are other appeals which the board retains the authority to preside over, and hearing procedures are needed to carry out those appeals hearings. Accordingly, the board approved the proposed addition to chapter 20 to MHBE's regulations, which essentially moved all of those hearing procedures out of that producer appeals chapter and into their own chapter. The board approved these regulations during the May board meeting. So this timeline that's up here shows the process that it took initially. We sent everything to stakeholders back in March for a 30-day comment period. There were no comments, and so it was presented to the board at the May 15th board meeting for a provisional approval and publication to the Maryland Register for public comment. It was issued in the June 30th Register for public comment, and there were no comments and no changes made through July 31st during that open comment period. And so the regulations that were proposed back in May are unchanged today, and we're seeking the board's approval for moving forward with final publication. So that is today, that's September 18th. We are here sticker. If the board would like to adopt these regulations as initially proposed and unchanged, there are just two more steps that need to be taken. First, they'll be published as a final publication in the October 6th Register, and then the regulations will be effective on October 20th. Any questions?
Any questions?
The next slide shows a proposed motion should the board like it.
So I move to approve adoption of the addition of COMAR 14.35.20 as presented and to publish the regulations in the Maryland Register October 6th issue to go into effect on October 20th, 2023 as presented. You get a motion to approve?
So moved.
Second.
Any discussion? Any opposed? Motion carries.
Thank you. Thank you.
So next on the agenda, we'll hear an update from Johanna on the regulation updates, starting with federal conformity.
First, I'm going to touch on plan certification standards, then switch to reg updates. So for those of you who are new to the board, we go through an annual process where we bring proposed plan certification standards to the board each fall, have a public comment period on those, and then ask the board to approve them towards the end of the year or in the new year. And this is pursuant to our state statute and regulations, which authorize the board to set standards that qualified health plans must comply with in order to be certified for sale through the exchange. So this is an annual process. We typically have some, updates that we've thought of over the course of the year or have gotten feedback from our stakeholders regarding plan design or different information that plans should submit to us so that we can display on Maryland Health Connection, things like that. This year, however, we don't actually have any proposed new certification standards to bring to the board for 2025. We're in a bit of a steady state on that front. We do anticipate that our value plan designs will need some slight adjustments, but we're not going to know what those need to be until the federal actuarial value calculator is released, because each year that federal tool, which governs how generous a plan's cost sharing can be, is updated. And then carriers have to update their plan designs to comply with those AB standards. So once that actuarial value calculator is released, which is typically in December, we'll take a look at our existing 2024 value plan designs and all of the cost sharing and that goes along with those, and look at whether we need to increase the max out of pocket, perhaps slightly tweak some co-pays in order to make sure that they're not too generous based on the actuarial value calculator. So we'll come back to the board in December or January with suggestions for the board to vote on that. But otherwise, we don't have any proposals. We did, as we do each year, talk to our standing advisory committee to share with them that at the staff level, we didn't have any proposals and solicit any feedback from them. We talked to them in their summer session and the most recent September meeting, and no one came forward with any proposals through that process. So there's no motion for the board to consider here because we're not proposing any changes. But if the board would like us to consider any changes, they can, of course, let us know.
Any questions? For Johanna? Secretary Lopez. Go ahead, Secretary Lopez.
Good afternoon, everybody. I just had a quick question as I was reviewing the memo on this particular item. There was a section on page 3 that mentioned the young adult subsidy program. I understand from reading it that there's only minor proposed text changes, but I was curious about the fact that since it was only for a few years, were there alternative considerations for continuation of that work if it was successful?
Sure, and that's moving forward into the regulation updates that we have to bring before the board, one of which is a slight change to the young adult subsidy regulations. So to that question, the legislature initially authorized the program as a 2-year pilot. We went back to the legislature this year and talked to them about the fact that 2 years is a very short pilot duration. We barely had a year of full data at the point of the legislative session in order to make recommendations about continuing the pilot. So we did initially propose a permanent kind of extension of the program. The legislature chose to do a 2-year additional extension through 2025, and then an additional assessment, in the run up to that about whether to continue the program based on the impact it's had. I think this part of the reason that the pilot design was chosen is that the money for it is coming out of the state reinsurance fund. And so there was some hesitancy to commit funding to that permanently until we see the results that the program delivers. So I think we have seen some great results. We have young adult enrollment that's up more than 10% year over year, nearly 7,000 new young adults in the market. And, there are many reasons that may contribute to that, but we think the young adult subsidy is definitely one of those. So we're continuing to examine it. And then I would also say that I think this is feeding into the overall larger conversation about affordability programs in the individual market that the Insurance Administration is leading under the auspices of their House Bill 413 work group that Michelle mentioned, where that report is going to come out with information for the General Assembly to consider on a variety of initiatives that they could think about to improve affordability in the individual market. One of the things that we are studying is an expanded state subsidy that's a slightly revised model, but that would be available to all ages instead of just young adults. So that, of course, again, depends on funding and other priorities. But I think it's certainly on the mind of us and our sister agencies and the General Assembly, and hopefully we won't see a kind of backsliding in affordability for these young adults.
Wonderful. Thanks so much. Appreciate that.
All right, so now I have 3 regulation updates for the board to consider. The first is a proposed regulation, and the second and third are both pretty minor changes for the board to consider for finalization of 2 regulations. So the first one are proposed federal conformity and policy updates. So just to start off, a note on our timeline, we're bringing this to the board on today. Of course, that first yellow highlighted square. Prior to bringing this to the board, we shared these with stakeholders for an informal 30-day public comment period, and then adjusted what we're presenting to the board based on the comments received. And then the regulations following the board meeting will be published for a formal 30-day public comment period, and then we plan to come back to the board to request a vote to finalize them in January. So the next slide gets into the substance of the regulations. So this grows out of the fact that each year the federal government, the Centers for Medicare and Medicaid Services, update the federal regulations that govern exchanges, and once those are finalized, we take a look at our state regulations and assess whether any state regs should be updated to be in conformity with the federal changes from the year. So the majority of what we're proposing here are just pretty pro forma tweaks to conform with the federal changes, but I'll run through them each briefly, and I'm happy to take questions on any of them. The first is to clarify that dependents remain on their parents' plan until the end of the year in which they turn 26. Federal law previously allowed, it required carriers to keep them on until the end of the month, with the option to keep them on until the end of the year. All carriers in our market have been covering young adults through the end of the year, so there's no change here, but our federal or our state reg parallel to the federal reg, or actually might not even have specified, but now we're clarifying that those dependents can remain on through the end of the year. The next is to give consumers 2 years, which is an increase from 1 year, to resolve situations where they failed to file their federal taxes and reconcile their receipt of advanced premium tax credits on those taxes. So it's definitely all a very federal process, but the feds have required that individuals stay up to date on their tax filing in order to continue to receive premium tax credits. And so this has been suspended during the pandemic, but the routine order of business is that the exchange runs a check early in the year to assess whether people receiving APTC correctly filed their prior year taxes. If they didn't, after some warning periods, the exchange is supposed to remove APTC from them. And so those individuals are left paying the full cost until they get their tax filing situation straightened out. The feds are modifying that process so that exchanges now will only remove premium tax credits through this process if consumers did not reconcile in 2 consecutive years of taxes. So you get kind of a 1-year freebie, but if for 2 years you haven't filed your taxes and reconciled your premium tax credit, then your premium tax credits are removed until you fix the situation. So that is anticipated to go into effect for plan year 2025. The current situation where the suspension is in place is where we are for this plan year. So we won't be removing APTC from anyone this fall, this new year, but next year we will probably start resuming these checks. It depends on the IRS updating their system. So we will stay tuned from CMS for when this resumes. The third conformity update is to increase the number of essential community providers the carriers must contract with to 35%. Our state standard was at 30%. The federal standard has fluctuated below that number. So we had always been at or exceeding the federal standard, but now they've exceeded our standards, so we're moving up to join them. Essential community providers are designated under state and federal law. There are things like FQHCs, Indian health providers, if they exist in the states, some other specific categories focused on providers that target low-income communities and uninsured communities. Our carriers all contract with around 35% or more of the ECPs in their service area, so we don't anticipate this will be a stretch for carriers to comply with. The fourth conformity change is to clarify that plan marketing names must plan variant marketing names in particular must be correct and not misleading. This isn't something that we personally have found to be an issue, but nationally, CMS identified that in some plan names, carriers will often put, say, the amount of the deductible, like the ABC carrier $1,000 $20 copay plan or something like that. For certain silver plans that are available to lower income individuals, they get cost sharing reductions, and that deductible will be lower than that $1,000, might be $200, but carriers weren't updating the plan name to align. So they were getting a little bit of confusion over the plan name. So this is a clarification that, you know, all plan marketing names need to be correct. The fifth conformity update is to establish a timeliness standard for notices of payment delinquency. Carriers were previously required to provide timely notice, but that wasn't defined. It's now being defined as within 10 days of the delinquency. And then the last item on this slide is to consider plan network when we are renewing individuals whose plan is no longer available into a new plan. So there's a federal hierarchy that governs how you map someone who's renewing into a new plan if their existing plan is not available in the new year, that tries to get them into the most similar plan available to them. Network was not previously one of the elements considered in that hierarchy, but it will be going forward. Any questions on these items?
Go ahead.
Go ahead.
I'm confused still on the marketing names and so say that piece again. I want to understand. So is it like a large corporation that has subsidiaries and the name tied to, just, can you clarify that?
Yeah, so specifically with silver plans, if you're below 250% FPL, you qualify for cost sharing reductions. And the plan design that you qualify for, there's 3 options depending on how low your FPL is. And carriers have to adjust their cost sharing for each of those variations. So the standard silver plan might have a $5,000 deductible, but one of their variations might have a $1,000 deductible. So some carriers were using that 5,000 in the name for all of those silver plans, the base and the variant. CMS is saying, no, use the actual deductible level for the plan the person is enrolling in the name of the plan.
Okay.
2 questions on the consumers getting 2 years to rectify tax filings. How many people does that affect?
It's a relatively small number. I can't remember well, it's been years since we've been doing this because it was suspended during the pandemic. And I don't know off the top of my head what the Maryland statistic was. I think the federal statistic that they mentioned in the federal regulation was something around maybe 10% or lower. Their rationale is that this disproportionately impacts low-income individuals who may have complicated tax filing situations and are eligible for substantial premium tax credits. So it's kind of particularly punitive towards them.
Is there any assistance? I mean, yeah, I can imagine tax situations can be pretty complicated. And consumers pretty much on their own. There's no consumer assistance that the exchange can offer to those individuals, I would think. Is anyone else doing that?
I think that like the cash campaign and, there are organizations that offer free tax filing assistance. Our navigators wouldn't do that, but they'd be able to connect people to those entities.
And on the essential community providers, so you have to contract with 35% of the ECPs in what?
In your
county,
service area.
state? And how much utilization of essential community providers? Is there a certain way exchange can track that? So you contract, but if you never get any service, don't be much.
That's a good question. We have not tried to. I think we could through APCD data, probably. That would be an interesting, something interesting to analyze.
Commissioner Bring had her hand raised.
Go ahead.
Hi, thanks. Just a quick question. Jahan, I was curious as to whether you received any comments about that 10-day period.
We did not, and it was finalized in the federal regulation, so there's not much that we could do about it after that.
Thank you. That was it.
Any other questions?
All right, the next set of federal conformity changes relate to modifications to our special enrollment periods, or SEPs as we refer to them on the slide. The first is a change to give consumers more options when they're losing minimum essential coverage, through their employer or another source. Currently, the way the federal regulations and our regulations were set up were to give people a coverage date of the first of the month after their loss of coverage, as long as they report the loss to us prior to the loss happening. So if they happen to lose coverage mid-month, they could have a gap in coverage until their exchange started the first of the following month. This regulation will give people formally the option to choose the first of the month in which they're losing coverage. So they might have a couple weeks of dual enrollment, but they wouldn't have a gap in coverage. This is very rare. We rarely see anyone asking for this or reporting that they're losing coverage in the middle of the month, but it provides more flexibility in that event. The next is a change to the loss of Medicaid and CHIP SEP for loss of Medicaid and CHIP. This was optional for states exchanges to take up. The federal exchange is instituting it, and we propose to follow in their footsteps. They're increasing the special enrollment period from 60 days before and 60 days after loss of Medicaid to enroll in a qualified health plan to 60 days before and 90 days after. We made some slight changes to the wording that are very minor based on some consumer feedback or stakeholder feedback. This, as a reminder, we have a special Medicaid unwinding SCP in place until July 31st, 2024. So through that point, anyone who loses Medicaid can enroll in a qualified health plan at any time between their loss and July 31st of next year. And then after that temporary special enrollment period ends, this expansion to 90 days after loss will start. And then the last proposed change is to remove the burden on consumers to demonstrate a plan display error if they're asking to receive, if they're maybe eligible for a plan display error special enrollment period. So this is a circumstance where the exchange misdisplayed some pertinent information that influenced the consumer's purchasing decision, and following that getting clarified, they want a different plan. Very rare also, fortunately. And I don't think we would have forced a consumer to prove it to us in the past if we could see it ourselves, but the language suggested that they had to. So now if we on our own identify that there was an error, the regulatory language supports us proactively providing that. Any questions on these?
So just so I'm clear, this is still cleanup language to align with the, okay.
Still all cleanup language. The next slide is our one policy proposal that is not tied to any kind of federal cleanup. And that is to limit the number of plans per carrier per metal level to 3 starting in 2025. It's currently 4, which it has been for years, maybe since for many years at least. But when we convened the 2022 affordability work group, which was a stakeholder work group with all our carriers and kind of representatives from all of our other key stakeholder sectors, they recommended that we reduce from 4 to 3 going forward to follow research that demonstrates that when consumers have too many plan choices, they can get paralyzed by the decision-making process and are more likely to choose a plan that's not financially the best option for them. It does for them and their family. So we haven't gotten any pushback on this proposal. And as I mentioned, the carriers were part of the work group that made this recommendation. All right. So with that, there's a motion.
Great. Any questions for Johanna on everything she just covered? So I move to approve the proposed regulations as presented and authorize MHBE to submit the proposed regulations as presented to the Joint Committee on Administrative, Executive, and Legislative review and to the Department of Legislative Services for publication in the Maryland Register. Can I get a?
So moved.
Okay, second, thank you. Any concerns or any opposed? All in favor?
Aye.
Aye.
Motion
Aye.
carries. So next up,
All right, our next regulation is concerning our Medicaid to private plan enrollment program. Just as a refresher background on this, as you all know, Medicaid terminations were suspended during the public health emergency and resumed this spring. And with that in mind, we created this program to simplify the enrollment process and coverage transitions for Medicaid enrollees who are no longer Medicaid eligible due to changes in their household composition or increases in their income, and who are now QHP eligible, with the goal of increasing the individuals who successfully transition and maintain coverage. So what this looks like in practice, as a reminder, is we automatically, there's sort of two routes into this, but if someone is determined QHP eligible once they've completed their redetermination, but they don't select a plan within a certain period of time, we've been going with 7 days, we will then automatically enroll them into the plan that follows a hierarchy that we shared with the board previously. We try to keep them in the same kind of parent company as their MCO if possible, if there's a private corollary. Otherwise, we enroll them into the lowest cost silver or gold plan in their region, and the medal level depends on their income. And so that process, we established a regulation. We can go to the next slide, through emergency regs that the board approved in February so that we could have them in place in time for the start of the unwinding. But emergency regs can only be in effect for 6 months. You have to go through the normal regulatory process to have regs that are in effect beyond that. So the board approved to transition the emergency regs as proposed regs on June 30th. So we published those as proposed. We haven't received any public comments and are just asking the board to finalize those regs for ongoing operations. And I think that's it. I'm happy to take any questions.
any questions for Johanna? Okay, I move to approve the Medicaid to private plan enrollment program final regulations as presented and authorize MHBE to submit them to the Division of State Documents for publication in the Maryland Register as presented.
Seconded.
Any questions or any opposed? All in favor?
Aye.
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 Motion carries.
And the next regulatory change is also pretty straightforward. As I mentioned, our current regulations assume that the program would only be in effect from 2022 to 2023, but legislation this year extended the pilot program through 2025. So we're just proposing a small change to allow the board to continue setting the eligibility and payment parameters for the program beyond 2023. I think the next slide shows the tweak to the language. So instead of saying specifically in 2022 and 2023, we're changing the language to say in any year of the program, the board has the authority to set the relevant parameters for the program. And the board approved these proposed regulations in June. We did not receive any public comment after they were published and are now asking the board to approve the final regulations.
Any questions for Johanna? I move to approve the final young adult subsidy regulatory updates as presented and authorize MHBE to submit them to the Division of State Documents for publication in the Maryland Register as presented. Can I get a
So moved.
Second. Secretary Lopez. First.
Oh, was that who it was? Okay, any opposed? All in favor?
Aye.
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 Motion carries. Thank you. So next we'll move on to the 2024 health plan landscape, which is also Johanna.
So I'll continue. This will also be pretty brief and straightforward. Slides, keep going. There we go. Yeah. So we annually present to the board on the plan landscape for the upcoming plan year. So as you heard, Aetna is newly re-entering the individual markets statewide. That doesn't really change this map. So the light blue and dark blue are statewide carriers, which now include Aetna, also United and CareFirst. The dark blue indicates specifically where Kaiser's service area is, but all the other carriers are also operating in those dark blue communities. In terms of the number of plans by metal level, you can see a 3-year breakdown of how many plans at each metal level each carrier is offering. We have 9 more qualified health plans in 2024 than we did in 2023. Those are all new Aetna plans. For the other carriers, number of plans is the same as the prior year, so no changes in number of plans for CareFirst, Kaiser, and And then here's a chart to make your eyes cross with deductible ranges and actuarial value levels, which is the measure of plan generosity, what proportion of claims on average a plan covers, as opposed to what proportion the individual pays through cost sharing. So again, we have a 3-year comparison here. No remarkable changes year over year in this data. We do see reflected in the silver plan actuarial value levels, slight increase in the lower levels in 2023. That's due, oh, and I'm sorry, these are misnamed. The years should be 2022, 2023, and 2024 at the top. So it is 3 years of data starting in 2022 through 2024. This whole slide says 2022 and 2023. This is really 2024 data. So in 2024, we see that the actuarial values for silver increased to a floor of 70%. The federal government shrunk the de minimis variation, as it's called, for actuarial values at the silver level. It used to be that silver plans could range between 68 and 72%. Now they can range between 70 and 72% because premium tax credits are benchmarked off of silver plan rates. By shrinking that floor and not allowing the lower value silver plans, that sort of boosts the tax credits for the whole market and increases consumers' buying power. So it's a good evolution. And then one
I have a question just on that last slide. So these deductibles, maybe I wasn't paying attention if you presented it before, pretty high. So, I mean, do we look at things like healthcare utilization between the 3 tiers, 1 and 2 of that healthcare utilization? I would imagine that gold is more primary, secondary prevention and, bronze is emergent, urgent care. I mean, is that what you're seeing based on these deductibles and the tiers?
Yeah, one thing I'll point out is that we're only showing the base silver plan deductibles and not those variations that people qualify for at lower incomes. When we look at taking into account those silver variations, I think something like 70% of our enrollees are in a gold or gold equivalent or better plan. So most people are not in those not so good looking silver and bronze plans. We did do an analysis with Hilltop a few years ago. We were particularly looking at whether we saw any changes in utilization in our value plans, but I think we also looked at differences in utilization between metal levels generally and saw what you would expect, that yes, the bronze utilization is more emergency. All plans do cover preventive care at no cost, so that's available even in the bronze plans. And starting in 2024, our bronze value plan, which all carriers are required to offer, does cover primary care, specialist, generic drugs, and speech and physical therapy with copays before the deductible. So, there's still a heavier cost sharing burden, but we ensured that consumers in a bronze at least have an option of a plan with more accessible coverage.
Commissioner Bryan, raised her
Thanks.
Quickly.
Oh, thank you. Just quickly. And Johanna, these are the numbers for the individual market participants that purchase through the exchange.
That's
Correct.
correct. Yes.
So, because about 30% buy off the exchange, I'm not sure that that's a big, huge differential in terms of where they wind up, but, and it's all that 70%, whether they have APTC or not.
Yes, that's correct.
All right, great. Thank you.
Did you say again the de minimis impact of the de minimis shrinking, and is it that you saw the most movement in gold? I just want to make sure I'm capturing what your
So
observation.
We do actually see in gold that the AVs bumped up a little bit. I don't have an explanation for that, Brad might, but I was referencing silver. That's where the allowed de minimis shrunk to just 70 to 72. So you can see in what's labeled 2022, but is really 2023, we had some AVs around 66, 67. And those inched up to 70.
And Johanna, to clarify, CMS changed the de minimis range on other metal levels too. And so gold what was allowed to go to -4 and now needs to go to -2. So that is part of what's going on gold as well.
Thanks, Brad.
And to this silver point, this de minimis change on the 70% is only for on-exchange plans. There are additional off-exchange plans that can go down to the old 68%, not the 66% from last year, but they can go down to 68% off-exchange. So there are more off-exchange plans than there are on-exchange plans. But this captures the range of off-exchange, except for silver, where off-exchange can still go down to 68.
Thanks, Brad.
Thank you. And then just one other question on the previous slide where it showed the total number of, I just want to make sure I'm interpreting these right. This is the total number of plans or number of new plans. I just wanted to make sure.
Total number of plans. So each different color is a different metal level, catastrophic, bronze, silver, gold, platinum, and then we have each carrier listed. Care First appears twice as an HMO and a PPO, and then we have the number of plans that carrier, total number of plans that carrier is offering at that metal level.
On the exchange.
On the exchange, yes. So yeah, all qualified health plan data for on exchange qualified health
Okay, that's helpful. Thank you.
Go ahead, Ben.
So question on how do you interpret an organization? Is it so Care First as Care First as GIMSI? Are you counting Care First as an entity? Care First is Care First is Care First, or are you saying for each of the entities they can each have 3?
So the HMO is just food choice, and then we've lumped the 2 PPOs into a single category. So we're only counting them once. If one of the PPOs has one plan and the other PPO has the mirror plan, we're just counting that as one plan.
Right, thanks.
We have another question from Erica.
Go ahead. I was going to ask something similar, but I just wanted to clarify, Donna, you mentioned that it's 70% of consumers are leveraging the silver and gold rather than the bronze.
That's correct. And specifically, they're in the silver tiers where they get cost sharing assistance, which brings the value of their silver plan to the equivalent or better of a gold plan. So approximately 70% of our consumers are in really a gold or better plan. Even if it's called a silver variant, it's functionally a gold or better plan.
Got it. Thank you. Yeah, I was looking at the actuarial value and I was just confirming the 2. So thank you.
And then last question on the previous slide is because we were previously you were talking about the observation of the abundance of choice and freezing decision making. I just curious how this compares and these, let's say 44 plans, is that the number by which we should think about the benchmark of choice? Seems low, but
Yeah, that's a great question.
just trying to get a sense of then how does that get compared when you're talking about that kind of and this whole body of economic research around that. Just trying to figure out how to think about that, and as we look forward, what's that benchmark that's kind of the tipping point?
Yeah, it's a really good question, and I don't know of research that identifies an optimal number of plans, but happy to look into that. I think we might have done a literature review on the topic, so I can look into that and get back to you. I mean, I think 44 plans is a lot. I think even 35 plans is a lot, but it's a struggle in the balance between wanting to allow carriers the opportunity to innovate, and as we're moving to just 3 plans per carrier, one of those plans will be the value plan that the exchange predominantly designs for carriers, and then 2 plans that the carriers can design on their own. At 3 or 4 plans per metal level, we are among the states that have stricter limits on the number of plans per metal level. The federally facilitated marketplace is starting to go down this path, but there are consumers in some states who have 200 plus plans to choose from, which would be very confusing. I always say, like, I have 3 plans at the state to choose from, and it still takes me a while to figure out what I want to enroll in. We are also planning to convene, in the vein of the affordability work group, a consumer decision support stakeholder work group this spring to help us think more about, even if there are 30 plus plans available to someone, how do we continue to improve the way we present that information that helps them not be overwhelmed, helps guide them towards the plan they want based on their preferences or a selection. So we do offer features now, like you can enter, as you're going through the plan shopping process, information on your anticipated healthcare utilization, and we will then automatically rank plans for you based on your total estimated annual cost of care, taking into account both out-of-pocket spending and premiums. If you're eligible for one of the high-value silver plans with cost sharing, we'll prioritize those and show them first in our search results, because those are probably the best option for most people to try to help them see that. you can search for plans that cover certain doctors, you can search for plans by whether they cover prescriptions you need. So we have a lot of tools out there, but I think there's still opportunity for us to improve that process. So we're going to be working with stakeholders on that next year.
Any other question? Oh, go ahead.
Johanna, may I recommend, and apologies if you've already thought of this yourself, but may I recommend that you and staff reach out to our SAC co-chair, Mark Meiselbach, because he is a health economist and a researcher in the private health insurance market. He may lead you in the right direction, may have some insight that will answer Laura's question.
That's a great suggestion, Dana. I'll do that.
Any other questions, Cynthia? Thank you, Shannon.
Thank you.
So next on the discussion, we'll hear the 2024 approved rates with trend and medical from Bradley.
Thanks. If you could go to the next slide, please. All right. At a high level for the rate review process, our regulations require that we review rates and make sure that they're not excessive, that they're not inadequate, and they're not unfairly discriminatory. And part of that is making sure they comply with all state and federal laws. We just had the discussion about the utilization between different metal levels. And while it is true that bronze has lower utilization and gold has higher utilization, that is not something carriers are allowed to take into account when rating ACA rates, because ACA rates must use what's known as a single risk pool methodology. So the claims for all members, regardless of what metal level they are in, are combined, and all metal levels are based on that combined experience. And the premium difference between metal levels is only supposed to reflect the actual benefit difference between those deductibles and not the difference in claims utilization of the population in those plans. So since that just came up, we do get that data by metal level, but that's not part of the pricing. So our rate review begins with looking at the experience period data. For this 2024 rates, the experience period was 2022. We looked at how the experience period came in, both compared to what carriers were previously expecting when they set 2022 rates, and compared to the year before, 2021. Then we start with the experience period, and then we review the assumptions to get to the projection period of 2024. The key assumptions in these ACA rate filings are the claims trend, which we look at by both cost and utilization components. In addition, by different service categories, carriers break down trends between hospital and professional and drug. Morbidity is a large factor, especially in the individual market. It's the relative health status of the pool. The more population change there is, the more morbidity change there potentially is. We look at carrier operating expenses. We look at the profit margins and the contributions to reserve. We look at assumptions regarding risk adjustment transfers, which are a very important component unique to this ACA marketplace. For the individual market only, the reinsurance recoveries under our state reinsurance program are a huge assumption that we review. In recent years, we've been dealing with the impact of COVID-19. In the most recent experience period data, carriers have shown that COVID-19 has dropped to a very small percentage of claims, and no carrier is projecting any significant COVID costs going forward, but we are still dealing with historic data that is distorted by COVID. And it distorted things in different ways in different years. So in 2020, there was a big decline of claims, which was counterintuitive, but it was because of the shutdowns, and all elective procedures were stopped for several months. And so the 2020 claims came in lower than anybody was originally expected. And then 2021 claims came in significantly higher, both because of direct COVID costs, because of the surges that were taking place, as well as rebound costs from 2020. And now things in 2022 and 2023 have gone, back to the normal level, but we need to adjust for that as we're looking at the historic claims pattern. And then finally, we have the impact of the Medicaid unwinding on the enrollment and the morbidity of the pool. And that is a big, uncertainty still. We have very little Medicaid data at this point. The unwinding has just begun. In general, carriers are not making very large adjustments for this component, but it is a large source of uncertainty that we're going to see over the next year, how it plays out and exactly how large of an enrollment impact it has. So all these rate filings were submitted back on May 22nd and were approved officially today. So if you could go to the next slide, I'll talk about the specific rates. So as Michelle mentioned earlier, in the individual market, we're approving an average increase of 4.7%. That compares to the 5.7% average increase that was filed back in May. And it compares to what we approved last year of 6.6%. Something important to note about this 4.7% increase is that this includes the impact of raising the reinsurance attachment point, which is the first time that this has happened since reinsurance started. So as a reminder to everybody, last year, because of the uncertainty around ARPA and whether it was going to be extended, the attachment point was lowered from 20,000 to 18,500. And so that kept last year's increase from being close to 8%, brought it down to 6.6%. But then this year we went the other direction. So when carriers filed back in May, they were expecting the attachment point to go from 18.5 to 19.5. After looking at where the rate increases came in and long-term reinsurance projections, the MHBE board finalized a $20,000 attachment point. And so the 4.7% is in spite of that attachment point increasing, which puts upward pressure on the rates. So if that attachment point had stayed steady both years, we would have approved something like 8% last year and something more like 3% this year. So that attachment point movement, what was a tool to help, flatten out the increases ultimately, but that should be taken, kept in mind when you're looking at this 4.7% average. The other thing I wanted to point out, that last column shows that, even with this increase, rates on average are 22% lower than they were in 2018, the year before we started the reinsurance program. That's absolute dollar values, despite claims trend, despite inflation over that time, we are still 22% lower on an absolute dollar basis than we were in 2018. And the last comment I wanted to make on this slide is that the total on and off exchange enrollment of 228,800, it's down slightly from last year. I know on exchange only enrollment is up from last year, but this is down about 1% from last year. But we are seeing that gap narrow because of the recent months with the Medicaid enrollment. We are seeing that uptake in the most couple recent months. So my expectation is that by the end of the year, this year should end with higher enrollment than last year, but at the snapshot of 6/30, it's down about 1%. Next slide, please. So I wanted to go through just some sample premiums to put dollar amounts to what people are actually paying, and also to show, some of the variation. All the increases on the previous page were averages, but by metal level and by plan, there are differences. So this is a sample set of bronze premiums. For each carrier, we're showing their lowest bronze plan. As Johanna's slide shows, every carrier except the Care First PPO has more than one bronze plan, but this shows their cheapest bronze plan. And it shows, what it was in 2023 today is the cheapest, and then what it's going to be next year in 2024. So you can see the PPO rates are coming down. And then on all the other metal levels, it's going to be slightly higher than this year. As a reminder, these are the unsubsidized rates that only about 30% of people pay. for the majority of people, especially the majority of people on exchange, their subsidy is gonna keep them, from feeling the impact of these rate changes. It's going to change the amount of their subsidy, not the amount that they pay post subsidy necessarily. But for anybody that purchases directly from the carriers or on exchange and doesn't get APTC, this is the premiums. These are sample premiums. Next slide, please. This shows the same thing. This is for it says bronze, but that can't be bronze.
It's silver, Brad.
Yeah, it must be silver. Sorry, I mislabeled the slides. So this is the same thing. This is for silver. On this metal level, you can see that there are more carriers decreasing rates than raising rates. And then next slide should be gold. Can you go to the next slide, please?
It is.
This
It's
is the
labeled
gold
wrong.
one.
Yeah, the labels got screwed up. Sorry about that. I'll send out an updated version. But yeah, these are the gold rates. And so once again, it varies by carrier. And then also included on all these sheets were the Aetna rates as well. So you can see where Aetna compares to the other carriers. In general, the Aetna rates came in clustered with the other HMO carriers. You have the 4 HMO carriers relatively clustered together, and the Care First PPO at a meaningfully higher rate level. But that gap between HMO and PPO has narrowed somewhat this year. All right, next slide, please. So this is another sample premium exhibit. This shows a couple different ages, and this shows the comparison of value plan premiums. So 2024 is the first year where the value plans are going to have the same cost sharing across the board rather than just more general requirements. So we put together this chart to show each carrier for each of the 3 metal levels where value plans are required, where their premiums are coming in for the different ages. And as a reminder, all the carriers have to use the same age factors. It's the age factors that, we're using the federal age factors. So, for any given age, the relativities between the carriers will be the same. So, the cheapest carrier for any given metal level will be the cheapest regardless of one's age.
And these are all
of these
unsubsidized.
Excuse me?
These are all the unsubsidized amounts.
Correct. These are all still unsubsidized amounts. All of these have also been for Baltimore County. This year, no carrier is geo rating, so these should be good for the whole state. But geo rating is allowed and has been used in the past. But at this point, this should be statewide unsubsidized premiums. But none of these take into account subsidies. All right, next slide. All right. Then as far as the individual dental side of things, we ended up approving minus 1.3%. That's what the carriers initially requested back in May. In general, about 75% of the dental consumers should see their rates fall, and about 25% should see increases. The increases are all low single digits, and everybody that got an increase this year should have gotten a decrease last year. So in general, there has been continued rate stability in this ACA dental marketplace. I will say that the enrollment here is also plateauing. We had seen very large enrollment uptakes over the past 3 years. It is still up year over year, unlike the medical side, but the gains have kind of flattened out. But the rates are slightly declining, and hopefully we can see continued gains in the future. All right, next slide, please. All right, Then this shows the small group ACA rate approvals. The purplish column at the bottom shows that the average increase we're approving is going to be 6.9% across all carriers. That compares to the 7.5% that was originally requested back in May. In general, a big driver of the higher increase in the small group market is a higher observed trend. In general, you know, the individual ACA trend, the average trend approved was 5.3%, which is pretty low in historic terms of trend, and you know, is supported by recent individual experience that this shows 2022 claims not increasing as fast as they expected, but the small group data is showing the opposite, and the average small group trend is 7.8%. Which is up 6.8% from last year. We spent a lot of time scrutinizing the data. You know, it's pretty well supported. You know, I will say that there's a risk that, you know, the trends could have come in even higher than the carriers are projecting. But that's the big difference between the individual and the small group market. And you know, we're still trying to analyze and understand, you know, that 2.5% trend difference between the two markets, you know, is the largest it's been since the ACA started. But, you know, another thing to note is that, you know, the variation between carriers has narrowed since the initial rate requests. You know, the original set of rate requests ranged from 1.4 to 20.4%. You know, the final approved increases range from 1.4 to 15.4%. And then just like on the individual side, these are averages. They vary by plan. There are 250 some small group plans. So very high choice, you know, unlike the relatively small choice with the individual market. So you know, there's a large amount of difference, you know, within each of these filings. Next page, please. So this shows some sample small group rates in the same, you know, kind of methodology as the individual rates. You know, these are illustrative rates for an individual on the left and a family on the right. Obviously, an actual small group would have multiple individuals and multiple families that are all added together. Once again, this shows that the cheapest plan from each carrier on this metal level. This shows silver. I did not put together a bronze illustration because bronze is a very small portion of the small group marketplace. And the large majority is in silver, gold, or platinum. But, you know, once again, you can see that, you know, there's a range, and you know, there are decreases occurring, even though every carrier is averaging an increase, you know, at the plan level, that there are some rate decreases occurring. Next slide, please.
And Brad, those are the whole premiums, right? This is not allocated between what the employer pays versus what the employee pays. That would be an individual decision by the employer. This is the whole premium.
Correct. This is the whole premium, employee and employer combined, and it would be split up in some way. And so this is the same kind of illustration, but on the gold medal level. All of these rates are published on our rate website. I did not include the link directly to the health review portion of our website in this slide presentation, but it's in the press release that went out earlier today. So you can see, you know, every single plan that carriers have, you know, on the individual side, it shows it for every single age and every single plan. On the small group side, it shows it for every single plan. And so, you know, all of this rate detail is public and published and can be accessed on our website. And if anybody needs help accessing any of it, you know, please reach out to me and I can assist you in doing that. But at this point, I'm gonna stop and ask if there are any questions on the rate approvals before I move on to talk about MLR rebates.
Any questions?
All right, great.
I have one quick comment to make, and that is that I cannot possibly stress to everybody here the impact of really the exchange on Maryland's rates, and particularly those value plans, because in my national work, I get to see what a lot of other states are doing, what those choices look like, what those options look like, and what those costs look like. And I have to say that while our work is not done yet, Maryland really is consistently one of the lowest, if not the lowest pricing, with some of the best benefits, right? Particularly with respect to out-of-pocket minimums, when you really sit down and start to look at what is available in other states. And a lot of that comes from this group and this board and the advisory committee, a lot of those constraints and controls that have been put in place over time. And then I will give credit to my team who, I can't even tell you what it's like and the detail they go into and what they demand for the carriers and what they require them to justify at every step of the way. But all of that combined effort together by what you do and what our actuaries do really make a difference, a real difference for Maryland consumers. And when you step back and you look at the national level, you really begin to see that. So that's not kudos to me, that's kudos to the Maryland Health Benefit Exchange, the people on the connector, and my actuarial team. You really make a difference.
Thank you for that, Kathleen.
Yeah, thanks for those kind words. All right, let's talk about MLR rebates then. Next slide. So just as a background, part of the ACA was to define a medical loss ratio calculation and set minimum standards in the individual, small group, and large group markets. The individual MLR for individual and small group is 80%. For large group, it is 85%. Pre-ACA, a medical loss ratio was generally a very simple equation, just claims divided by premiums. The ACA complicated things and made the equation a little bit more complex, but it's still basically claims over premiums. But now you need to take into account reinsurance adjustments, risk adjustments, and then on top of claims, carriers are allowed to add in QI expenses, which stands for quality improvement expenses. So that's like care management type of stuff that's being spent directly on improving patients' outcomes, can be included as part of the claims component. And then you also get to adjust out taxes and fees from the denominator. So the MLR is computed at the market and state level. So if it's a national carrier operating in 50 states, they file the MLR for each of those 50 states. And then it is computed for each market separately. It does not distinguish grandfathered and ACA. So the individual MLR, when the carriers report it, is a combination of all grandfathered and ACA policies. At this point, grandfathered is a very small portion of the total, pretty trivial for every carrier except for CFMI. But in past years and in the earlier MLR years, the grandfathered portion mattered more. The MLR was a requirement before the ACA plans even began in 2014. And so, they have been computing MLRs since 2011. A key component of the MLR that's also overlooked a lot is that it's a 3-year average. So carriers only owe a rebate if the 3-year average of their MLR is below the minimum. And it's been a 3-year average since 2013. So next slide, please. in addition to the 3-year average nature of the calculation, another important component for smaller carriers is a credibility adjustment. You know, in general, a larger a carrier is, the less random claims variation is going to affect their loss ratio. And the smaller they are, the more that random variation is going to impact them. So as to not to penalize small carriers, there's this credibility component. So if a carrier has less than 1,000 life years, which, you know, is a life year is, you know, on average 12,000 member months, it is not credible at all, and no rebate will be owed regardless of the MLR. We don't have any carriers that small in our marketplace at this point. And then there is a credibility adjustment if a carrier is between 1,000 life years and 75,000 life years. And we do have several partially credible carriers in our market. And so the credibility adjustment is made to the MLR. And then basically, if the MLR is below the standard after the credibility adjustment is made, then a rebate is owed. And the rebate amount is basically computed as, you know, 80% minus whatever the carrier's actual MLR is times the average premium. So, you know, if they came in at 75%, then the calculation would be, you know, 80% minus 75%, 5% times premium. And you know, that's gonna be the basic calculation. For members in the individual market receiving APTC, the MLR rebate depends on the unsubsidized premium, not what they are actually paying in post-subsidy premium. So it is possible for people with high APTCs to receive a rebate greater than the amount of premium they've actually paid. There is no mechanism for the federal government to recover any APTCs in this scenario, so they just luck out in this situation. Next slide, please. So carriers have to submit the report every year by July 31st to CMS. So the 2022 report was just due this past July 31st. After they submit the report, any rebates that are owed must be issued by September 30th. So that's in a couple weeks. Rebates are owed to all policyholders who had a policy during that reporting year. So for anybody that's still active, the carrier can choose between issuing a rebate check or giving them a premium credit. But anybody who has lapsed and is no longer with the carrier must be issued a check. Next slide, please. All right, so as far as the rebate history for Maryland goes, this is for the individual market. I've listed out each carrier. At a high level from 2011 to 2018, there were no rebates. Like I said, 2011 was, you know, but before the ACA market actually started, but at that point, carriers had loss ratios that were high enough that rebates were not being given. The early years of ACA, carriers were losing lots of money. Their loss ratios were 100% plus, nowhere near that minimum. But then in 2019 was the first year that the loss ratios came down and the carriers had rebates. So the total rebates in 2019 were $26.9 million. That represents 2.2% of total premium in the marketplace. You can see that it was all Care First. You know, that some of that is driven by market share. And then in 2020, it went up to 72.5 million. That was 6% of premium. And in 2021, that fell to 44.8 million, which is 4% of premium. The 2022 numbers have not been published by CMS yet. They take several months after they received the carrier's reports to put them all online. But as I'll walk through on the next slide, the expectation is that the rebates are going to be a lot lower because of the rolling 3 nature of the calculation. And it was 2019 and 2020 that really had those very low loss ratios. So if you can please go to that next slide. Hopefully I didn't make these numbers too small. But this shows how the loss ratio calculation works on a rolling basis. So if you start in the top section for 2019, you can see for each carrier, the details of their MLR by year for the most previous 3 years. All of these come from the public reports that can be pulled online. I have links later in this presentation for them. But you can see in 2019, the MLR that 3-year loss ratio, you know, the carriers had a pretty high loss ratio in 2017. You know, all the carriers, you know, the lowest loss ratio in 2017 was 88.7, which is way above the 80% minimum. Then for 2018, things came in a little bit lower for some carriers, but then it was 2019 where the loss ratios really were way below the minimum. And as mentioned earlier, that was driven by COVID. No, sorry, I'm skipping ahead of myself. 2020 is COVID. 2019 was driven by the reinsurance program. At a high level, you know, when we implemented the reinsurance program, morbidity had been increasing at a very high double-digit rate per year. We expected with the reinsurance program to halt and reverse that morbidity and, you know, worsening and to, you know, have the pool stabilize and for things to start improving. But all of us carriers and regulators thought it was going to take a couple years for things to turn around and really turn around quicker than we thought. And so the 2019 loss ratios were really driven by the reinsurance program having a bigger impact sooner and quicker than expected. So you can see, you know, the 3-year averages by carrier for 2019. You have Care First Blue Choice at 76.6, that's below the minimum, and Care First CFMI PPO at the 74.8. The Care First CFMI is not fully credible, so they got that credibility adjustment that I noted there. So at the end of the day, you know, both of those entities had to rebate about 3.5% of premium, which when translated to the total market from the previous slide was about 2% of total premium. Then when you step down to the next section for the 2022 MLR, 2017, which was a bad year, dropped off, and then 2020 was the new year, and that's where COVID kept the loss ratios down. And so for the 3-year average for the 2020 MLR, you can see that the 3 Care First entities came in significantly below that 80% minimum. You know, the 3-year averages for the 2 PPO entities are in the 60s. Blue Choice is at 72.2. And so that's what drove those large level of increases or large level of rebates in the 2020 year, that the $72 million rebates. And then going down one more year, you can see 2021. And for
Can you
this,
say what that meant back to the individuals?
as
On
far
average, what was
as
their rebate out of pocket?
that data is contained in the CMS reports, yes. I do not have it at the tip of my fingers, but yes, all of this, we know how many members were eligible for these rebates, and these can be translated into per member as well.
Yeah, I think that would be helpful moving forward, because a lot of time people don't feel, right, the delta, especially if we say in policy, this is what will happen, yet people don't feel like that money actually gets to them.
Yeah, I can certainly put it in those terms as well next time.
Okay.
And so, yeah, with 2021, you know, the 2021 1-year MLR for each carrier came in significantly higher for CareFirst, and you know, that drove their 3-year average back up again. So you can see that the 3-year average for CareFirst in 2021 is higher than it was in 2020. They still owed rebates. And then you've also got Optimum Choice Inc., the United entity that came in. 2021 was their first year. And they came in with a 71.3% loss ratio for their first year. They get the biggest credibility adjustment because they're the smallest company, but they still owed a rebate in this year. But like I said, you know, because of the 3-year nature of the calculation, we know that in 2022, when the rebate is calculated, that the 2019 numbers are going to drop out. So those low loss ratios in 2019 are no longer going to be part of the 3-year equation. And then the 2022 loss ratios are going to replace those 2019 ones. And we know those 2022 loss ratios are fairly as well as are fairly high as well. We've got the financial statements from the carriers that were filed back in May. They don't line up perfectly with the MLR, but just based on those financial statements, you know, we know that CareFirst, you know, is definitely going to have loss ratios well above the minimum for the 1 year of 2022. And so, you know, the expectation is that the 3-year averages are going to come up meaningfully from 2021, and the rebates should drop. But like I said, those will be finalized soon. I mean, they are finalized. CMS will publish them soon. Mid-October is the typical timing of when they publish things. Last year it got delayed till February of the following year for some reason, but mid-October is more typical. The next slide, please. So these are the links that I was talking about. That first link is a tool to get a carrier-specific report. You select a year, you select a state, and you select a carrier name, and it will pull up that carrier's reports. 2011 through 2021 can currently be downloaded. 2022, sometime between October and February. When you go to download things, you're going to get a zip file. It's going to have every report the carrier submits in the whole United States. Just search for the Maryland file. All of them have, you know, state abbreviations in them. And then the second link is a more generalized MLR resource from CMS where they publish some high-level reports. And so I'm going to show some examples of those high-level reports. So if you could go to the next slide, please. So this is the first report they pay or they publish, and this gets to that rebate per person question. So Maryland is 2/3 of the way down. This is the 2021 rebate report, which you can't see in the heading. But you can see that in the leftmost column, the total Maryland rebates were 53.4 million to 228,000 consumers in the next column. And that was an average rebate of $234 per person. But then if you keep going across the column, all right, yeah, the way I cut this screenshot, cut off some of the information, the order of this file, the first set of numbers is individual, then small group, then large group. And so, you know, in the Maryland row, that 44.894 million rebate, that's the individual number that matches the slide I showed a couple slides ago. So 177,919 individuals in the individual market were eligible for those rebates, and that averaged $252 per person. And then you can see that the rebates in the other markets for 2021 were significantly lower. It was 1.6 million total in small group and 6.9 total in large group. But this report format is available for every year from 2011 to 2021. And you can see each market, what was paid. And then if you go to the next slide, please. And then there's a second report available for each year that shows it by carrier within each state. This report only includes carriers that actually paid a rebate. So it doesn't have every carrier that sells business in the state. If you have 0 rebates in all market segments, you're not included. But this shows the rebate amount owed for each carrier in each market segment in each state across the country. And once again, this excerpt is from the 2021 report, but they have it available for 2011 through 2021. And I focus this report on the individual rebates. In general, you know, there have been small group and large group rebates more years than there have been individual rebates. You know, 2011, I think, might have had rebates in those segments. But in general, the group rebates have tended to be smaller as a percent of total premium. You know, I think what I walked through with those individual loss ratios and how low they really were in 2019 and 2020, there's not been that magnitude of miss in the group marketplaces. But like I said, this report is available and it shows, you know, whether your carrier in your market should have owed you a rebate. And I guess one thing I forgot to mention is that, you know, as far as those rebate checks go, in the individual market, they're obviously sent to the individual. And in the small group market, they are sent to the small employer. And it's the employer's responsibility to distribute the rebate to its employees. And they're supposed to do so proportionally to how they split the premium. So if it's a 75% employer contribution, 25% employee contribution, the employer is supposed to pass on 25% of the rebate to their employees. And I think that's the main things I wanted to talk about MLR rebates. Any questions about what I walked through or about the resources that are available from CMS?
Well, and I think, Brad, to the Secretary's point, we can take some of this data and we can provide some more concrete examples, and also in the individual market, how this interfaces with APTC, right? For folks who are receiving APTC, so people who are still in plans. So we can provide just a little bit more information about what this actually means for a person who is buying their insurance through the connector, as well as people who are buying insurance off exchange.
Yeah, we can, and we can get, you know, that how much it actually is per member. We have that available for each year, and yeah, we could get that detail and put that together.
Go ahead, Ben.
Brad, thanks a lot for the presentation. For small and large groups, what's the enforcement agency in the federal government? Is it regarding the sharing of rebates with employees? Is that IRS or SIO? Who makes the determination that fund rebate checks that go back to employers are appropriately distributed?
I mean, I think
not knowing is an okay answer.
So we have an enforcement responsibility here that we oversee, right? The percentage is based on the plan itself, who paid it in the first instance. So not every plan divides up the employer versus the employee's portion in the same way. That's not driven by law. But the requirement to rebate exists at the federal level, and then the MIA does exercise a high level oversight function to make sure that the rebates are being paid, and that there is the biggest issue that comes around, frankly, is when they can't find somebody. So, you know, they've tried to send a check out to someone who's no longer enrolled, an employer that's no longer in existence, and then what are their requirements? What does the federal law, the federal regulations require them to do in that instance?
Yeah, and I will add that, in the group market, premium credits are a more common type of format to issue these rebates. Just because persistency is a lot higher and it's a lot more likely that your group is still around. There are some still checks mailed. I mean, any small group that ceases to exist, that the carriers are still responsible for finding those employees. But the majority of small groups are stable, and premium credits are ultimately a more common mode in the group market than the individual market.
Thank you.
Thank you, Brad. Any other questions? Okay, thank you, everyone. So we're going to go back and take a second vote on the young adult subsidy final regulations. We had a procedural error, so I'm gonna make the motion and then we'll take another vote. So I move to approve the final young adult subsidy regulatory updates as presented. And this was the last presentation that Johanna did, and authorize MHBE to submit them to the Division of State Documents for publication in the Maryland Register as presented. Can I get a motion to accept?
So moved.
Can I get a second?
Second.
Yeah, I heard Dana.
Any discussion? All in favor?
Aye.
And any opposed? We good?
You're good.
Great, thank you. So, we're good? Okay, okay. So I want to thank everyone for the presentations today and for the overview. Our next meeting is scheduled for October 16th. There is no closed meeting anticipated at this time, and so we'll close the meeting and see you next month. Thank you, everyone.
Thank you.
Thank you.